you very much indeed, ladies and gentlemen. It's my pleasure to present on behalf of my colleagues the results of our randomized prospective placebo-controlled trial. For a randomized double-blind phase 3 study of panobinostat or placebo plus bortezomib and dexamethasone in relapsed or relapsed and refractory multiple myeloma. Now, by way of introduction, obviously the field of deacetylase inhibition has been particularly intriguing and important in hematologic oncology in particular, and panobinostat is one of the hydroxyamic family of deacetylase inhibitors, is a potent pan-deacetylase inhibitor that increases acetylation of proteins involved in multiple oncogenic pathways. And I illustrate here on the left some of the key targets that we believe are involved. And in that same context, this pleiotropism results in synergistic activity with bortezomib and dexamethasone in both preclinical studies, and most importantly, is suggested in a number of phase 1 and 2 studies to demonstrate not only robust responses, but durable responses in heavily pretreated relapsed and refractory myeloma. Now, in the context of panobinostat and its ranking in comparison to other deacetylase inhibitors, there are some important qualities to emphasize. First of all, there's a differential inhibitory activity towards HDAC enzymes between the various drugs that are currently under evaluation. And most importantly, panobinostat demonstrates low non-molar activity against class 1, 2, and 4 HDACs. What's particularly interesting too is the role of HDAC6. I just want to bring your attention to the low non-molar concentrations compared to beronostat, for example, and similarly even to molybdenum as well. Very interestingly, ACY1215 and clinistat appears to be particularly active at low non-molar concentrations in the same HDAC6 pathway. What's particularly interesting is how these various drugs will develop and pan out in the setting of our treatment of myeloma. In that context, it's worth just reminding everyone of the mechanisms that underlie how this drug works. Our hypothesis is that there is dual inhibition of the degradation of the protein degradation pathways, the degranulation pathways that are so important in myeloma cell biology. And what's critical here to understand is that panobinostat inhibits this rescue pathway through the agrosome that is upregulated when the proteasome is inhibited. Now, I think what's important to recognize is that there are other mechanisms in play as well, and the epigenetic effects of these drugs, I think, are well understood now and recognized as being very important. So with that as a background, and with the success of the phase 1 and 2 programs with the combination of panobinostat, bortezomib, and dexamethasone, Panorama 1 was launched as a randomized double-blind phase 3 study in relapsed or relapsed refractory myeloma. 768 patients were enrolled and randomized either to panobinostat, bortezomib, and dexamethasone, or placebo, bortezomib, and dexamethasone. There were two major phases to the treatment program. The first phase was 8 3-weekly cycles for a total of 6 months, and then in patients who were deriving clinical benefit, they moved on to the second phase, in which there were 4 42-day cycles, again over 6 months. Now, the primary endpoint was progression-free survival, confirmed by an independent review committee. A key secondary endpoint was overall survival. Other secondary endpoints included response rate, the quality of the response encountered, the durability of treatment benefit, quality of life, and safety. And importantly, the study was conducted at 215 centers across 34 countries. Now, I just want to remind people about the treatment schedule because it is somewhat complex. In that regard, just to emphasize that bortezomib and dexamethasone was given according to the classical schedule, 2 weeks on and 1 week off. And panobinostat was given versus placebo 3 times a week on days 1, 3, 5, 8, 10, 11 schedule. And during the first phase here, as you can see, the classical 2 weeks on, 1 week off. During the extended phase, or phase 2, cycles 9 through 12, the same strategy was deployed, but bortezomib was administered weekly, and again, therefore, the cycle length was that much longer across 6 weeks, but this break and the weekly bortezomib was noted. Now, at the time of the design of the trial, subcutaneous bortezomib had not, of course, been approved, and so in that context, bortezomib was administered intravenously, and obviously the remainder of the agents were oral. So here is a summary of the patient characteristics and baseline demographics. As you can see, for this sort of population of relapsed refractory disease, the characteristics were fairly typical. Median age of 63 3, the time from diagnosis was approximately 3 years. The ISS distributions were again very even. And in terms of the relapsed refractory versus relapsed population, approximately 2/3 were relapsed and 1/3 were relapsed and refractory. The majority had had prior transplant. The median number of prior lines of therapy, of course, was 1 to 3 was permitted. This fourth illustrated it was a single patient. It was a protocol violation. In the context of prior therapies, 40% had received prior bortezomib, a significant proportion had received prior lenalidomide, a larger number had received prior thalidomide, again reflecting the international nature of this trial. And interestingly, about a quarter of both arms had received both bortezomib and immunomodulatory therapy. It's important to note that patients who were bortezomib refractory were obviously ineligible for this study. And also importantly, approximately half of the patients had 2 or more prior lines of treatment. Now this is the patient disposition as of the time of the data cutoff of the 10th of September last year. As you can see, almost all patients have completed their treatment, and a significant number of patients entered the second phase, approximately half in both arms. The interesting differences start to emerge when we look at disease progression for panobinostat, bortezomib, and dexamethasone versus the control group, and importantly also when one looks at the adverse event profile as well. The median duration of follow-up is approximately equal. In that regard, obviously, there's ongoing analysis for survival, which we'll come to in a moment. Now, if one looks at dose intensity, we've sought to summarize it here. The important message here is that the relative dose intensity of panobinostat decreased to about 80%. Dose reduction was 20 to 15 at cycle 3, but remained fairly stable through the remainder of the trial. And the median duration of treatment was somewhat shorter for panobinostat, bortezomib, and dex than placebo, but again, the difference was not marked. This is the primary endpoint of the trial, and as you can see, progression-free survival did show a highly significant and clinically meaningful difference. For panobinostat, bortezomib, and dexamethasone, it was 12 months, and for the control group, bortezomib, and dexamethasone, it was 8.1 months. This was highly statistically significant, and we thought clinically relevant, with an increase in median PFS of 3.9 months for the experimental arm. Now, in the context of subgroup analysis, which was pre-planned, some interesting trends emerged. First and foremost, as you can see from these forest plots, that according to race, sex, age, and clinical staging by ISS, the effect was fairly consistent. What was interesting to us was that in a small number of patients with poor risk cytogenetics, as defined by 17B, 414 translocation, and 1416, we did see effect, but we recognize obviously the confidence was not broad. What's interesting about this, though, is it resonates with observations in earlier studies where we've seen a particularly interesting signal in high-risk cytogenetics. When one looks at slightly more conventional approaches in the sense of more clinical features, the same trend emerges. Those patients who had prior use of bortezomib had had prior exposure to immunomodulators, and interestingly had seen both, and were also, most importantly, relapsed and refractory. The benefit in terms of progression-free survival was most marked. Now, when we look at the key secondary endpoint, which was overall survival at interim analysis, no significant differences yet emerged, although the numbers are trending in favor of the 3-drug arm, recognizing this follow-up remains early. We'll have to see with the final overall survival analysis after 400 events, 515 events have been reached, what the outcome shows. Right now, as you can see, we're at approximately 286, so we've got a ways to go. Now, in terms of efficacy as assessed by response, and interesting trends emerge. For overall response, there is a difference in favor of the 3 drugs, but it trends to significance but doesn't achieve it at this point. However, if you look at CR and near CR, there is a significant difference in favor of the 3-drug combination. And interestingly, whilst in the context of this trial, the statistical design did not allow for a significance assessment of this difference, we did see clinically important differences in duration of response, time to treatment response, and median time to progression. So in this regard, these were two differences that we thought were important, and I should emphasize that median time to response was actually rarely in favor of the 3 drugs, but this again is a shorter interval. So what about adverse events? Well, in this context, there were several non-hematologic adverse events that were of primary interest based upon the experience that we'd seen with voronostat in combination with bortezomib. And what we were looking at here was primarily GI side effects and fatigue. This was also informed by our experience in phase 1 and 2 studies. As you can see here, there was a high rate of all-grade diarrhea and fatigue, and indeed an important estimate for significant fatigue and diarrhea in this context, and this was different control group, in which it was significantly less. However, dose reduction and supportive care, this proved generally manageable, and this is reflected by the discontinuation rate of 4.5% for diarrhea and 2.9% for fatigue. But obviously, an important side effect, as I emphasised, with these relatively low rates of discontinuation, obviously an encouraging result in that regard. Now, in terms of hematologic lab analyses, some other important trends emerged. The discontinuation rate due to thrombocytopenia was low. Having said that, the differences between the two arms, certainly for grade 3-4 thrombocytopenia, were noteworthy. Interestingly, also in terms of grade 4 neutropenia, this was harmony control as well. So the hematologic picture is relevant, but when one looks at this clinical sequelae, such as febrile neutropenia, there wasn't a meaningful difference, but there was a small but important difference in grade 3-4 hemorrhage noted. So we looked carefully at platelet kinetics to best understand this, and this actually shows it very nicely. As you can see, from the 3-drug combination, the nadirs are lower, but over time, the cumulative trend is to a gradual improvement over time, and what you can see is that the thrombocytopenia is clearly reversible and not cumulative. And most importantly, following an initial decrease in platelet levels during the first 2 weeks of treatment, platelet levels rebounded to baseline by day 1 of each cycle. Now, if you look at the treatment deaths on study, the principal causes of deaths are summarized here. Deaths due to progressive disease, and total deaths on study. We looked at this very carefully because of the difference that was observed here. Albeit the overall rates are low, this difference we thought was noteworthy. And as you can see, they're summarized to the left and to the right. What's I think important, though, is that deaths possibly related to study drugs per the investigator assessment were not markedly different. So we were relatively reassured by that aspect of the assessment. So in terms of the summary, we think that this study clearly demonstrates the superiority of the 3-drug combination over the control with an improvement in median progression-free survival of approximately 4 months. What was particularly striking is that the PFS benefit was maintained across all subgroups, and what was also intriguing was that there was an almost 2-fold increase in the high-quality response rate of 28% versus 16% in this population of relapsed and relapsed refractory patients. Now, obviously, this came at a price. There was a higher rate of diarrhea, fatigue, and thrombocytopenia, but the good news is the adverse events were predictable and generally manageable, but I would emphasize they were important. Supportive care, however, was very helpful. These results also confirm other studies, which we've summarized here. And moreover, we believe, therefore, that panobinostat constitutes a significant advance in this field, and especially in the treatment of patients with relapsed disease. We recognize the superiority of the 3-drug platform in this population mirrors other randomized trials that we've recently done. But I think what's critical here is that this establishes histone deacetylase inhibition as a novel mechanism of action in this setting, and the activity in high-risk populations is particularly promising. Now, what about future directions? Well, a critical point here is that the use of sub-Q bortezomib may substantially improve tolerability. Importantly, other combinations with panobinostat are under evaluation for myeloma. And excitingly, there are other HDAC inhibitors under study which have the promise of similar efficacy and potentially less toxicity. And interestingly, at this meeting, we've already heard that panobinostat has seen very promising results in other hematologic cancers, including myelofibrosis. So I want to conclude with our acknowledgements, particularly to our patients and their families who participated, the clinical investigators and their teams, the study sites and the staff. I want to especially acknowledge the preclinical investigators, including my own colleagues, Terry Schumann, Jay Radner, and Ken Anderson, the early study team involved in phase 1s and 2s, our independent review committee who provided superb support, and last but by no means least, our sponsors from Novartis, who stuck with us the whole way with this study, provided superb support at every level. And finally, I want to conclude by acknowledging the clinical investigators across the globe who participated in this trial. Thank you very much for your kind attention.